As the public interest in sports has risen, so has the money involved, which in turn has allowed for a new kind of profession, the one of professional athletes. The huge salaries and social prestige that come with belonging to the best of the best make it no surprise that athletes are seeking out every competitive advantage possible. Cycling especially is famous for doping, probably because all of its requirements are very easily doped, from low body fat to increased red blood cell count to better recovery in multi-day races and even psychological help in the form of stimulants and more. Apart from this, there is also the willingness of the governing body, the UCI in this case, to enforce their anti-doping policy and punish riders accordingly. But they don't always appear to be too concerned with this, especially if a high-profile athlete is involved. So, let's visit the Union Cycliste Internationale website and pull up their list with prohibited drugs, which is composed by the World Anti-Doping Agency, or WADA. I'll give a quick overview of what these drugs do to the human body and thus why they're banned. The list starts off with anabolic androgenic steroids. All of these are essentially some kind of variant to the naturally occurring primary sex hormone found in males, testosterone. Most people will now immediately think of bodybuilders. That's because protein synthesis, and thus muscle size, is indeed one of the processes stimulated by these drugs. While this increase in muscle mass isn't necessarily advantageous in a sport so dependent on your power to weight ratio, it also has some other, less known effects which are extremely beneficial. One of them is that these drugs directly stimulate lipolysis, or the breakdown of fat tissue, allowing the users to achieve much lower concentrations of body fat. Another is that they stimulate your kidneys to produce more EPO, which in turn will increase your red blood cell count and with it your body's oxygen carrying capacity, something that's invaluable in any endurance type sport. Now, this hematocrit is just one factor influencing your VO2 max. There are also other aspects like how efficient your lungs are at exchanging gases, how efficient your heart is at pumping blood to your working muscles, the amount of capillaries in your muscles and thus the surface area available for gas exchange between blood and said muscles, as well as other things like the concentration of oxidative enzymes in your muscle cells. All of these factors are not so easily doped, and to improve these will just require many hours of training. Luckily for the dopers, testosterone helps with this as well, because it significantly reduces recovery time needed between sessions, thanks to the above mentioned increased protein synthesis, as well as a reduction in inflammation. So, testosterone-doped athletes are able to train harder, longer, and more often. Next on the list is probably the most famous cycling drug, erythropoietin or EPO. EPO is another naturally occurring hormone produced by the kidneys. It travels through the blood to the bone marrow, where it basically orders more red blood cells to be pumped out into the blood. A recombinant form of EPO was originally developed for the treatment of chronic kidney disease as well as chemo-induced anemia, but quickly found its way into the endurance sports. With more red blood cells, you're able to carry more oxygen to your working muscles, which significantly increases the amount of energy you can produce aerobically, so without the production of lactate. Then come the peptide hormones, for example, chorionic gonadotrophin as well as luteinizing hormone. Both of these are drugs that can bind to the same receptor in the testes and cause them to start producing and excreting more testosterone. So they are essentially forcing an increase in endogenous testosterone production instead of the direct administration of testosterone seen previously. The results, however, will be similar. Also belonging to peptide hormones is growth hormone. This is another one famous in the bodybuilding world because of its similar effects to testosterone. It also increases protein synthesis through insulin-like growth factor 1 and thus increases muscle mass and strength. It also increases lipolysis as well as improves recovery times. Then come the growth factors, which, incredible but true, are named that way because they make things grow. Each of these can bind to a specific type of cell and signal it to start dividing. To give a few examples, fibroblast growth factor will cause connective tissue, found for example in muscles and tendons, to grow and repair. Insulin-like growth factor 1 will heavily stimulate protein synthesis and thus increase muscle size. The growth hormone we've just discussed works via this IGF-1. We have also vascular endothelial growth factor, which will cause more blood vessels to form, which in turn will improve oxygen delivery to working muscles. Beta-2 agonists are drugs that stimulate the beta-2 receptors of the orthosympathetic nervous system. Yes, that same part of the autonomic nervous system that is responsible for the fight or flight response. These beta-2 receptors can be found on various types of tissues, but most notably are probably those in the lungs. That's why these drugs are commonly inhaled with the use of inhalators, and you might already be familiar with these as they are standard in the treatment of asthma. The effect of inhaling beta-2 adrenergic agonists can be seen as a localized effect of the fight or flight response. In other words, the small airways in the lungs expand, allowing for more airflow, optimizing gas exchange and putting the organism in a better state to fight or flight. Aromatase is a naturally occurring enzyme that is responsible for the conversion of androgens to estrogens. Aromatase inhibitors block this enzyme and thus prevent this conversion from happening. They are often taken in combination with exogenic androgens to prevent them from being converted to estrogens and causing unwanted effects like breast growth in males, also known as gynecomastia or just man boobs. It also causes the androgen concentration to remain ever so slightly higher because there's no loss due to the conversion. In a similar fashion, we find antiestrogenic substances on the banned list. These drugs block the effect of estrogens in the body. Normally they're used in women with breast cancer, for example, as these tumors have receptors that cause growth in response to the naturally circulating estrogens. Block the receptors, block the growth. However, through interference with the complex feedback system that regulates testosterone, some of these drugs, like tamoxifen, can actually cause an increase in testosterone concentration. As you can see, many of these banned drugs directly or indirectly cause an increase in androgens. They just have such incredible performance-enhancing properties that they're the reason why we must hold separate competitions for men and women, and why change of competition through being transgender is such a controversial topic. That leads us to another interesting group of drugs. Under normal circumstances, we have an activin receptor 2B that is involved in the production of another protein, myostatin. Myostatin in its turn is known to inhibit muscle growth. It essentially prevents muscles from becoming obscenely large, as that would prevent proper movement and, evolutionary speaking, survival. So imagine a drug that blocks the activin receptor 2B. The result will be a reduction in myostatin, and thus no more prevention of excessive muscle growth. If you want to know what these types of drugs would result in, we already have some famous examples of myostatin deficiencies. The first one is the Belgian Blue, a breed of cattle which has a natural mutation in the myostatin gene, causing it to lose its function and thus allowing muscles to grow out of proportion. Another example is the German track cyclist Robert Forstemann, who has a congenital myostatin deficiency. Next up we have the metabolic modulators. Among these are most notably the insulins and the insulin mimetics. Insulin is used in diabetic patients whose pancreas has lost the ability to produce endogenous insulin. Without insulin, muscles are unable to take up glucose and use it for energy production. But in healthy athletes with normal insulin levels, taking adequate amount of sugars during exercise, more insulin doesn't result in an increase in endurance performance, since the rate of glucose uptake is not the limiting factor. Where the performance enhancement does come from is the fact that insulin and its mimetics cause an increase in the previously mentioned IGF-1, which was also increased by growth hormone, and which will result in an increase in protein synthesis and thus muscle mass. And then finally we have diuretics. These types of drugs are used in patients with high blood pressure or edemas, as they essentially tell the kidneys to remove more fluids from the body. They're not really banned for any performance-enhancing properties, but rather because the increased amount of water that is lost in the urine can dilute the concentration of other substances one is trying to test for, and so mask the use of them. Next up are some drugs that are only prohibited in competition, but not outside of it during training. This might sound strange, but it's because these drugs don't actually enhance one's underlying physiology. They just make it psychologically easier to maintain a certain effort. One group, for example, are the stimulants. There's a big list of banned stimulants, which include, for example, amphetamines. Not so long ago actually, up until 2004, caffeine was considered enough of a stimulant to make it onto this list. Also banned in competition are some narcotics, as their pain-killing effects can help someone push harder than he would have been able before. Also banned are cannabinoids. These don't actually have any performance-enhancing properties, they actually impair it, but they are just banned because they violate the spirit of the sport, according to WADA. And then finally we have glucocorticoids. These are very potent anti-inflammatory as well as immunosuppressive drugs. If taken during competition, they can reduce sport-induced inflammation and pain, allowing the athletes to recover more swiftly, which could be a huge advantage in multi-day races, for example. But even in a one-day race, they could allow an athlete to push himself harder than what he normally would be capable of. Glucocorticoids, however, are not banned out of competition. Why is that? Because they are a huge double-edged sword with many side effects that increase with dosage and duration of taking them. And I speak from experience. I've been on them for over a year now, with huge doses in the first 3 months. Just to name some of the side effects: abdominal weight gain, loss of muscle, a round swollen face, stretch marks, hypertension, osteoporosis, thinning of hair and skin, a buffalo hump of fat in the neck, and many more. Just for reference, the medical name for the condition where one has too many glucocorticoids in their body is Cushing's disease. And these unfortunate people look like this. So glucocorticoids are only banned in competition because if you're taking them chronically outside of competition, you're not going to be competitive anyways. And with that, we have arrived at the end of the list.